So there are multiple prospective studies which have proved this point, but there's only one properly done clinical trial run, from Korea, where a multicentric study was done to show the non-inferiority of sentinel node navigation surgery along with partial gastrectomy. The primary endpoint being the evaluation of 3-year disease-free survival. A dual tracer was used and frozen was sent if positive, lymphadenectomy and D1, if not a local treatment. The short-term results have been very encouraging, where the mortality and morbidity are comparable between the two groups. The only thing is there is longer operative time in the sentinel node navigation group, and still it was proposed as an alternative considering the good quality of life associated with function-preserving gastrectomy and good weight gain after the surgery. And the good thing, the best part is this study was followed up with a 5-year study which showed significantly no difference between overall survival and disease-free survival between the groups that underwent functional gastrectomy as well as radical gastrectomy. So when done with sentinel node navigation surgery, the difference between overall survival, disease-specific survival, and disease-free survival is not different, although there was higher incidence of metachronous tumors in patients undergoing partial gastrectomy. There was no difference in the survival. So it was suggested as an alternative treatment to radical gastrectomy for early gastric cancers in view of better quality of life after functional gastrectomy and good preservation of function and good weight gain after surgery. So which tracer or which dye is good? One systematic analysis done by Hong shows that radioactive iodine with ICG is the best. If not, only ICG is the better approach. Either submucosal or subserosal, both are equally good. Coming to advanced gastric carcinoma, ICG helps in attending the extent, clearance, and lymphatic mapping. This is one large study done from China where they have detected the lymph node retrieval after ICG usage during surgery is significantly high. As you can see, endoscopically, dye is given a day before, and lymph nodes are retrieved during surgery and sent for biopsy. And as expected, the ICG group has significantly higher lymph nodes retrieved more than the non-ICG group. And the best part is, in the ICG group, there is compliance to D2. The non-ICG group, there's deviation from D2 regularly, whereas in ICG group, there's a significant compliance to D2. The same group were followed up for longer 3 years, and it was significantly shown that 3-year overall survival is higher in ICG group compared to non-ICG group, and the recurrence rates are also only half compared to non-ICG group. The other advantages is lower bleeding because better delineation of blood vessels, and great advantage in obese patients. The additional benefits like shorter operative time, assessment of perfusion after anastomosis helps the surgeon to sleep better, identification of infrapyloric vessels in pylorus-preserving gastrectomy, and incorporation of robotic surgery has changed a lot because the Firefly has given a great advantage in detecting the lymph nodes. And the smaller prospective studies have shown that robotic gastrectomy with ICG compared to laparoscopy with ICG retrieves more lymph nodes on average, at least 45 lymph nodes, which is significantly more than laparoscopy. And an interesting finding is the lymph nodes are retrieved in toto. Rarely you see damage, so the lymph nodes are properly counted in robotic surgery. To conclude, let's not jump and come to a conclusion as such, because these are two meta-analyses released just 2 months ago, both released at the same time. One says proceed with caution because neoadjuvant therapy significantly changes the outcome, so don't trust ICG. The other says it's an excellent tool, go ahead. So to conclude, for early gastric carcinoma, definitely functional gastrectomy with sentinel lymph node surgery is an excellent tool. For advanced carcinoma, lymphadenectomy is definitely easy with ICG. But we need more RCTs to confirm and also to standardize the procedure. Final word, Dr. Huang, who's popularized the ICG, says ICG is like reverse parking. Everybody knows reverse parking, but with lines, we appear like we are an experts at reverse parking. Same thing with gastrectomy. When we have ICG, it appears that we are experts at removing lymphadenectomy. It makes our job easy. It is not a replacement, a good surgical technique. Thank you.